Good afternoon, and thank you for joining us for this webinar on Medicaid utilization data. I'm Craig Thornton, and I'll be the moderator for today. Before we get started with the presentations, though, I'd like to turn the mic over to our coordinator, Bryce Overcash, to give you some tips about how to get the most out of today's session. Bryce?
Thanks, Craig. At the bottom of your audience console are multiple application widgets that you can use. You can expand each widget by clicking on the Maximize icon on the top right of the widget or by dragging the bottom right corner of the widget panel. If you have any questions for presenters during the webcast, you can click on the Q&A widget at the bottom and submit your question. We will address as many questions as possible during this session, but if a more detailed answer is needed or we run out of time, it will be answered later via email. We do capture all questions that are asked during the webinar. If you have any technical difficulty, please click on the Help widget. It has a question mark icon and covers common technical issues. However, you can also submit technical questions through the Q&A widget. Please note, most technical issues can be resolved by pressing F5 or Command+R on Macs to refresh the player console. A copy of today's slide deck and other resources are available in the Resource List widget indicated by the green File icon at the bottom of your screen. Finally, an on-demand version of the webcast will be available approximately 1 day after today's event and can be accessed using the same audience link that you used to access today's webcast. Now I'll turn it back over to Craig.
Thanks, Bryce. So discussions about Medicaid and CHIP often start with the fact that programs cover a lot of people. Currently it's about 74 million people, 20% of the U.S. population. Or it talks about how much these programs cost, $550 billion in 2016. But today we want to talk about digging into those numbers a bit more to understand kind of the services and products that all that money buys for all those people. That is, we want to talk about utilization data. So the analysis of utilization tends to look at three buckets of services. Within the fee-for-service system, there's all the long-term care stuff, and then there's all the acute care services. And then there's the big bar here of managed care. And later in the forum, we'll come back to the important topic of understanding what's in the black box of managed care, or maybe I should say here, the large dark blue bar of managed care. Within these buckets, the utilization data let you drill down and look at a lot of different kinds of things. Here we talk about how much treatment is being provided, or an example of treatment being provided. We can see the use of the drug Abilify, which is used in treating schizophrenia, bipolar disorder, and major depression. The data also lets you look at things like trends. So here we see trends in use of 5 drugs, over time, and how it's changed. And again, this is just total expenditures here. And while that's pretty useful, utilization data lets you do a lot more than just this. You look at the volume of a specific drug or prescriptions, visits, stays. You look at who's using a service or a drug. Are it kids? Is it adults? Is it people who are eligible for Medicaid because of a disability? You can ask what else is being used. So what's going on for people who are admitted to the hospital? What do we see before or after they're in a hospital stay? You can look at the variation among states and over time. And all this stuff can help you develop measures of quality and access. In other words, Medicaid utilization data is a real gold mine for understanding what is actually happening in Medicaid and CHIP. So to give you a better idea of what's in that mine and how to extract value from it, we have 3 of the top utilization data experts here today. Lindsay Loninger will start first. She's a senior researcher here at Mathematica, and she's going to review the types of utilization questions Medicaid data can help answer. She'll also be covering some examples, tools, guides that have been developed to help researchers use this data effectively. Next, we're very pleased that David Mancuso is joining us to share some empirical findings that highlight what can be done with Medicaid data. David is the director of the Research and Data Analysis Division at the Washington State Department of Social and Health Services. And he's going to be presenting utilization findings about behavioral health integration initiatives that are underway in Washington State. Finally, Sue Liu, another senior researcher here at Mathematica, will close the presentations by looking forward. In particular, she'll look at how the new features of TMSIS will make it easier to analyze utilization data and what future developments might help even more. At the end of our discussion, there'll be a short panel discussion, and then we'll open up to questions, and you can click on the box as Bryce indicated. So with that, I'm pleased to turn the microphone over to Lindsay. Lindsay?
Great. Thank you, Craig. So in this overview presentation, I'm hoping to convey 3 broad points. First, Medicaid claims and encounter data systems, which I'll subsequently refer to just as claims systems for short, are uniquely powerful resources to answer vital policy questions, but they are derivatives of very complex systems, and this complexity can present some fairly appreciable usability challenges. Finally, and fortunately, a wonderful array of technical assistance tools have kind of grown up around these systems that help end-user researchers. And while some are proprietary, many of them are free and publicly available for anyone who's interested in using them. So the way that this is going to work is that I'm going to present some specific examples to demonstrate these 3 points. These are intended to be introductory. They're not in any way exhaustive. And I'll be leaning heavily on NPR resources because these are the ones that I'm most familiar with. I also want to note here that we've compiled a toolkit, which is a bibliography. It will be publicly available after the forum at the end of this slide deck that includes and goes beyond all of the examples that I'll mention in this talk. So if an example or a particular tool happens to pique your interest, I encourage you to come back, look at these slides, and take a look at the toolkit. So the first type of research question we'll cover is descriptive analyses, and I think Craig keyed this up really well. So these are really the bread and butter of so many claims-based research activities. The simplest class of descriptive questions are snapshot in time reporting or measurement over a single time period. And I think a particularly timely example of that is that Medicaid claims data systems are serving as an integral part of the data backbone that's really standing up quality monitoring initiatives supporting value-based purchasing innovations in Medicaid right now. So why Medicaid claims data? What are their strengths in descriptive contexts? Well, across different states, the Medicaid claims data systems exhibit a good bit of harmonization with respect to the types of fields and coding systems that are used. And what's nice is that these standards are also broadly shared with Medicare and private insurance systems, facilitating comparability across payers. Another very important thing to note here is that many Medicaid claims data systems have sample sizes that are large enough to cover small but very high priority populations. Again, a recent example in the news are beneficiaries with opioid use disorders. So a variety of technical assistance tools in the form of standardized technical specifications or tech specs have grown up around supporting 2 key associated tasks with descriptive research. So the first is actually creating your outcome or quality measure, and the second is identifying your study population of interest. And these 2 tasks, although they sound simple, can actually be devilishly hard when you get down to the details because they can require wrestling with somewhat complicated coding schema like diagnosis and revenue and procedure codes. And what's wonderful about the tech specs that have grown up to support these types of analyses is that they have pretty complex measurement algorithms that have been laid out nicely in a user-friendly way. So some of these tech specs are proprietary, but there are a lot of good free examples and case studies in the Medicaid space, and I want to flag 2. So the first are the adult and child core sets, which are measure sets with associated tech specs that are designed specifically for the Medicaid population and are published on the CMS website. I also want to highlight some work that's in development that we are working on with our partners at Brandeis and NCQA and supported by CMS that's developing a whole slew of new measures, quality measures, that are pertaining to vulnerable Medicaid beneficiaries, and those technical specifications will be part of that work as well. A second type of descriptive research tracks beneficiaries over time. So drawing on 2 cool recent examples from the in-progress work I just mentioned are analyses interested in, for example, prescription drug adherence among high-risk populations or continuity of care for after detox for those with substance use disorder diagnoses. So why are Medicaid claims data good for longitudinal looks at the data? Well, in addition to the strengths that I discussed on a prior slide, they also have a nice particular strength that these are living systems. They continue to operate and have operated for a long time. So they often have consistent time series availability in contrast to, for example, nationally fielded public surveys that can have differing measurement years that aren't consistent. So the thing about longitudinal research is that it requires a somewhat deeper sophistication with respect to the underlying data system that you're using and potential changes over time. So here's where a second type of tool comes into play. And these are user guides that have been written by other researchers doing similar work. I want to point everyone to one that some folks at NPR have developed. That's a user's guide to the MACS data system, which is the National Medicaid Claims Database. But I also think this is an instructive resource for those working with, for example, state claims databases, because it gives an overarching framework with which folks can sort of get their feet wet in understanding how these data are structured and how they work. I also want to mention that there's some interesting work in the clinical literature. So if you hop on PubMed, there are some clinical resources from epidemiologists who have built cohorts using Medicaid claims data, and they have really instructive ideas and examples for how to build clinical cohorts. I think the particularly strong application of this is in the prescription drug literature. So we'll transition now to talking about the second broad class of questions, which are predictive in nature. And I think an application with which a lot of folks are aware is risk adjustment, both for rate setting and capitated payment arrangements, and also for performance scoring and quality measurement. So you'll see here in the wide Medicaid claims data bullets, some common themes are emerging, right, carried over from the descriptive work. I think the other thing I'd like to note specifically, though, is that often claims data are widely available to accountable entities, such as managed care organizations or ACOs, accountable care organizations, who will have these data on hand to construct quality measures or other measures themselves. Here again, I think tech specs are a wonderful research tool for end users. I've put two here on the slides that are valid and reliable and are in widespread use in Medicaid risk adjustment applications. I'm actually going to go a little bit wonky and detailed here with this next point, but some colleagues at NPR have done some really good creative work to develop a risk adjustment algorithm that permits apples-to-apples comparisons across dual-eligible and non-dual eligible beneficiaries, which can involve some fairly creative data wrangling since it involves Medicare and Medicaid data. So I'd like to flag that for those interested in risk adjustment for the dual population. There's another type of tool that's grown up that I think are really interesting, and those are comprehensive guides that explain risk adjustment, both the guts of the data, but also the guts of the empirical machinery, to end users such as state policymakers and others who are consuming this type of research, but who might not be producing it. And the reason why these guides are helpful is not only for the end users of algorithms, but actually as a researcher, I've leaned on them too, as sort of a design checklist, making sure I'm hitting all the right things, and also that I'm explaining them properly in a way that end users can understand. So a second example of predictive uses is developing risk scores to support population health initiatives, such as targeted case management. One of the challenges with this particular application right now is that it is very hot, and it can be very difficult to separate the hype from the true value. So Tom DeLear, a colleague of mine at Georgetown University, sat down and we thought about this issue, and we wrote up an issue brief that walks through when it's appropriate, and perhaps more importantly, when it isn't appropriate, to look to predictive analytics for Medicaid contexts. So in addition to this tool, I also want to flag that there are some really wonderful use cases that have been written up and disseminated on the CMS website pertaining to Medicaid superutilizers, which again is a very hot topic right now. And I think these use cases are useful for both researchers and for state end users when they're thinking about how data can inform programs for the superutilizer population. So the final research use we'll cover is evaluation research. And claims data are widely used to evaluate the impacts of program and policy changes. So here on the slide, you'll see two examples speaking to very timely, relevant policy issues of concern: delivery system redesign and the use of beneficiary financial incentives. You'll also notice here again that the key strengths of the claims data are carried through and they follow through from the descriptive and the predictive uses. I'm going to table the discussion of challenges and related tools for a couple of slides. And I'm going to take us now, we're going to transition from talking about all the cool research things that claims data can do to getting real about some of the very real and hard challenges inherent in their use. A first key challenge is the presence of missing data. And really, this issue can crop up in a variety of pernicious ways. For example, sample coverage issues. So often the extent of missing data can systematically differ across different beneficiary populations, which can really foul up the conclusions that you can reach from different analyses. I think the canonical example here is what Craig pointed out earlier: our beneficiaries served under managed care arrangements. We know that there has historically been a lot of missing data associated with encounters. Something else I'd like to flag that can be a little bit thorny is that these days, as we think about value-based care and supporting value-based models with Medicaid claims data, is that to make that fly, you need to be able to attribute beneficiaries to their accountable entities, whether it be providers or MCOs, the accountable entity of question. And historically, the provider identification and the MCO identification fields are either not there entirely, or they have very limited data, even when the field is technically present. So how do we work around these things, those of us who toil in this type of work? So I think we spend a lot of time on data field usability assessments. We spend a lot of time reading before we actually dive into the data. I want to flag some really wonderful usability assessments that some NPR colleagues did pertaining to MAC's managed care organization and behavioral health organization data. And again, I just want to highlight that while this is focused on MACs, it provides a really useful data quality assessment framework for folks using Medicaid claims data, perhaps coming from other types of systems. So I really recommend reading these. I also would like to flag just a wonderful TA guide that was published by the Center for Healthcare Strategies that helps people wrap their heads around linking Medicare and Medicaid data for dual eligible beneficiaries. And finally, and again authored by CHCS, are some wonderful use cases of best practices and patient attribution in Medicaid ACOs. There's also a related NQS effort on patient attribution that I think is instructive for people who do this kind of work. A second challenge is making valid comparisons, or answering that very fundamental compared to what question. So one particular context of this is finding relevant benchmarks for quality reporting applications. So sometimes, as a researcher, you have on hand a way to create meaningful benchmarks internal to your own data resources, but often that's not the case. And you want to look externally to benchmark what you've found to what else has been found across other aggregate groups, whether it be defined by population or by geography. So we're doing a lot of thinking here at NPR right now around benchmarking. But there's a lot of good currently available tools that I'd like to highlight too, and you see those in the sub-bullets on these slides. They're all great ways to orient thinking around what benchmarks are out there and what might be instructive. So the other hard comparison issue is making causal conclusions for impact analyses and evaluations. So this is asking the question, is any estimated effect I'm seeing real, or is it driven by statistical noise, or general time trends, or any of a number of potential biasing influences? And that is a hard assessment to make and something that takes a lot of time and critical thinking. And what's interesting is that in the clinical literature, there's a huge, vibrant literature on grading systems and evidence grading systems and how to draw and when not to draw causal conclusions from research. There's less of that in policy research spheres. but it does exist. And the one that we've put in this toolkit that I particularly like is from the What Works Clearinghouse, which is an education policy research resource, but it's super relevant for health research too. Oops, I skipped a slide. Sorry about that. So the final limitation I'd like to discuss is that often we want the reach of the data to extend beyond the data fields available in claims system. And this is sort of uniquely true when you're planning and evaluating cross-agency programs. It's fun because I think we're seeing a lot of enthusiasm and activity in this area with linked data right now, and I've picked an example for this slide from each of the research questions: descriptive, predictive, and evaluative, where linked data across administrative systems are supporting very cool, innovative uses. But while this is possible and doable, linking data across systems can be very technically hard. So here again, I urge folks to look at the existing technical assistance materials that are out there. There are some wonderful use cases from state Medicaid agencies that have been developed under the Medicaid Innovation Accelerator Program and posted on the associated website. I also want to flag that some NPR colleagues have written a great TA brief on linking Medicaid data with vital stats data. And what's interesting is here again is where the clinical literature can actually be super instructive for policy researchers. There are some really nice published studies in the clinical world on data linking of moms and babies and using vital statistics and claims data. So transitioning past the current limitations and looking towards the future, I'd really like to conclude on a hopeful note. As you'll hear from Sue Liu in our final presentation, TMSIS, which is spelled out here on the slide, represents a big push forward on the national data front with respect to some of the discussed limitations that we've gone through. Also, it's really exciting to see a bunch of innovative analytics that's bubbling up from the states right now. It's getting disseminated, adopted by other states, and growing the broad-based analytic impact of claims-based research, which is really neat to follow. So speaking of state-based analytics innovation, it's now my pleasure to turn it over to David Mancuso from Washington State.
Thanks, Lindsay. That was probably the best overview I've yet seen of the opportunities and challenges in using Medicaid data. So thanks for a great introduction to the topic. So this is David Mancuso. I'm a research director for a state agency here in Washington State. I'll be providing an example of how we use claims data to perform program evaluation in the Washington Medicaid context. And I think there'll be meaningful parallels to how other folks would do state-focused analytics in the Medicaid area more generally. And if we go to the next slide. So the specific context here is work that's underway in Washington State to integrate the delivery of physical and behavioral health care. And I have a slide here which has a lot of stuff on it, and in part the complexity of the policy-related information here. The delivery system information here is really the message that in our state we're moving from a very siloed, one might say fractured, approach to delivering mental health and substance use disorder services, which are what comprise behavioral health services. We're moving from a very fractured approach where we have two large state agencies that are responsible for different portions each of the mental health delivery system and the substance use disorder system. And starting with some major changes implemented last April, we've moved towards, in one region of the state, a more fully integrated managed care approach where for a given beneficiary, they'll be enrolled with a single plan who will be responsible for physical health care, mental health care, substance use disorder services. And in the balance of the state, we've moved towards a first step of integrating mental health and substance use disorder services within integrated behavioral health organizations. So these are the changes that we want to study in terms of major delivery system changes, policy changes in the state Medicaid environment. And if you're working in the state environment, understanding delivery systems at this level of detail generally going to be relatively important because it's going to have implications for how you might need to organize data to analyze it appropriately, to help ensure that what you think might be a really cool finding is not actually an artifact of changes in how IT systems are operating or changes in the delivery system or policy environment. So that would be one thing I would encourage folks who are doing work, especially work focused on a particular state. And I think if you're working with data from multiple states, this is an issue that extends across the states you'd be looking at data for. It's going to be important to develop some mastery of the evolving policy environment, essentially the IT system environment, to really understand your data well. So this slide, before we move on from this slide does convey some of that delivery system complexity in the state. It does leave out a lot of other important considerations, some of which, essentially the concepts Lindsay introduced in her presentation, that there are other aspects of complexity in the Medicaid environment that I think are generally beyond what one would see if one's used to working with commercial data, for example. You have issues of dual Medicare enrollment, which is going to be a non-trivial part of the high-risk Medicaid population in particular. And if your focus is on long-term care, that's going to be probably the majority of the population that you're looking at. And that dual Medicare enrollment is just a facet of third-party coverage. Other payers who would generally be primary in a Medicaid context, and we generally have to think very carefully about whether folks with third-party coverage should be in or out of the analyses we're doing, because we're generally going to be missing critical utilization information, which we use to identify risk factors for risk stratification and so on. So issues around dual Medicare coverage, more generally third-party liability. In a state like Washington with a significant tribal population, we have tribal carve-outs. Issues of the type of Medicaid coverage. Is it full scope Medicaid coverage, or are you looking at someone with a type of coverage that has a more limited scope of benefits? Leveraging on that, if you're comparing across states and you're looking at states who've done Medicaid expansion and states who haven't, one would have to think about the coverage groups that you're looking at and whether it's an apples-to-apples comparison. So that eligibility aspect of measurement, which in the way we think of that term, at least in our work here, extends to Medicare dual eligibility, third-party liability type of Medicaid coverage. Those are really important complementary considerations that almost certainly need to be connected to how you're measuring utilization, for whom you're measuring producing quality metrics, those kinds of considerations. And if you're not carefully attentive to that eligibility or enrollment side in terms of Medicaid enrollment, then there's a good chance you might not be doing it right. So just know that eligibility enrollment married to claim and encounter utilization data, those generally go hand in hand. All right, so on to the next slide. All right, so the particular context that I'm describing today, looking at major changes in how we're organizing physical and behavioral health care. The changes, these are changes which aren't really what you might often be studying, which is a particular clinical intervention, is a new pharmaceutical for a new condition associated with better or worse outcomes than folks with who would have received other medications to treat that condition. That would be a different type of study than what we're looking at here, which is a context where we're really changing the managed care structure of the delivery of services. And I say that even though in our old world we had local government organization, counties, we had a state agency who were performing those healthcare plan-like functions of building and maintaining provider networks, doing utilization management, service authorization, some forms of care management or case management. So even in our old world where we had managed care organizations as traditionally understood doing some of the management of services, and some organizations that you would think of as a traditional behavioral health managed care organization, we also had government entities performing MCO-like functions. And what we're moving to in our new world is a different constellation of organizations performing those health plan-like functions with greater integration and fewer points of accountability for the outcomes of Medicaid beneficiaries. And in this context, it's natural for us to look towards things like HEDIS. And if you're doing work in this area, you're probably already familiar or becoming familiar or need to become familiar with HEDIS as our probably, I think certainly our most extensive quality measurement platform for health service utilization, designed for commercial, Medicare, increasingly applied in the Medicaid environment. So we're bringing in this family of measurement tools to understand changes in beneficiary experience over time as different kinds of organizations are accountable for managing their health service experience. We are also, though, needing to fill the gap in areas where HEDIS has been, the standard tools available to us more generally have been less well developed to meet measurement needs focused on behavioral health populations. And that is a gap which is closing year by year as a variety of organizations, and Lindsay's presentation indicated this. There's greater and greater development of standardized measurement tools, quality metrics, broadly speaking, focused on beneficiaries with behavioral health needs and the provision of services to address those needs. And that's a great thing for us because we're always interested in being able to leverage somebody else's stewarding of major definitions, because that's a fairly heavy lift. But at this point, we still have complementing NCQA HEDIS and other major steward behavioral health metrics. We still have a family of homegrown measures. And we also have a perhaps uniquely comprehensive integrated environment here where we can also bring in homegrown measures that get at other experiences that we might put under the heading of social outcomes, like housing stability or employment or criminal justice involvement. And we'll look at some data related to that. So these are the measures that we're focusing on, and ultimately what we'll be analyzing are relative changes in beneficiary experiences over time in regions that are changing in different ways. Some that are already going into fully integrated managed care, others where the integration is this first step of an integrated behavioral health organization, where before we had a more fractured approach to the delivery of behavioral health services. So on to the next slide. And the measures that we're focusing on group fairly neatly with the ability to put some measures under multiple headings under concepts like access to care. Are we seeing changes, relative changes in access to primary care, access to behavioral health services? Are we seeing increased engagement, which we would use something like psychotropic medication adherence metrics as something we might put under an engagement heading. Measures of quality or coordination, much of what's in HEDIS we would think of as aligning neatly under a quality rubric. We see more measures that are getting at coordination concepts. I'm thinking in the behavioral health context, new HEDIS measures that look at access to mental health or SUD services after an ED visit with a primary diagnosis with those conditions. Those are the kind of measures we might put under that heading. Of course, we're really interested in tracking broad measures of utilization, which connect most strongly with costs. So measures of inpatient admissions per 1,000 member months or outpatient emergency department visits per 1,000 member months. And as I mentioned already, we're very interested in the social outcomes because the subset of the Medicaid universe who's most likely to experience adverse outcomes on measures related to housing stability, employment, criminal justice involvement, child welfare involvement, those populations are those with significant behavioral health risk factors. And we'll see some baseline data that points at that. And that really gets at the last bullet here, which is that there are major disparities in many outcomes between beneficiaries with significant mental illness or substance use disorder issues. And one of the things we want to understand as we are implementing more integrated approaches to managing these Medicaid benefits is, are we starting to reduce those disparities, which essentially is one of the key pathways towards broader objectives related to cost containment in the Medicaid environment. Okay, on to the next slide. So in terms of the data portion of the presentation, we're really focusing just on baseline information and some charts that illustrate what I've just described, which is the significant baseline disparities that we see when we apply a behavioral health risk lens to a state's Medicaid population. And what you're going to see here for Washington State, I have little doubt would largely be replicated in other states' experiences and, of course, rolling up to the national perspective. So on to the next slide. We're going to start with a couple of slides that focus on probably our most important metrics from the utilization perspective. Although I would also put some measures of long-term care service use certainly in this category of areas related to high costs, potentially impactable and avoidable costs. But for today, we've got information that's focused on two measures of events per 1,000 member months. The MM here refers to member months. And this is an example of a measure I mentioned before, the importance of doing measurement where one is thinking very carefully and precisely about the enrollment in Medicaid, and to the extent that we're talking about attribution of experience to managed care organizations, there's also the concept of enrollment with a particular plan over a particular reporting window. But this is a measure where you can't create it as designed without having that be a facet of the calculation. And what we're comparing here, this is calendar 2015 data, so this is all the last full calendar year before we've implemented these major changes. And this is a slide which illustrates how vast the disparities are in utilization between Medicaid adults with significant behavioral health risk factors and those without. Now, we're doing our behavioral health risk classification using actually one of the tools that Lindsay highlighted in had listed in her presentation, which is the Chronic Illness and Disability Payment System risk grouper, which has a variety of useful purposes to which it can be put in the Medicaid environment. We can use it as a tool to provide predictions about costs. It can be used in that kind of predictive modeling context. But it also provides, it's one of the many tools available to us to provide a way of classifying beneficiaries based on the presence of health conditions. I like the CDPS because it's got a built-in hierarchy, which can be useful. In this context, we're leveraging its hierarchical classification of psychiatric disorders to break out a subset that we would consider is more seriously mentally ill than a somewhat broader population with mental illness. And that concept aligns better with how in the old world our behavioral health carve-out had access to care standards designed to focus on those with serious mental illness. So that SMI population here is focused more on schizophrenia, meaning bipolar, major recurrent depression. Just putting in a plug for leveraging those kind of tools into this kind of work in ways beyond just the way they were initially designed to do. We see a recurring theme here, and we'll see this when we look at some of the social outcomes as well. Folks with co-occurring mental illness and substance use disorder, very, very round numbers, very roughly speaking, 3 times the risk of let's say, adverse outcome relative to the general Medicaid population. So 3 times, roughly, slightly under 3 times the ED utilization rate, closer to 3.5 times the inpatient admission rate observed in the general Medicaid population. And there's a substantial part of the population with these risk factors. So these are not small behavioral health risk groups. Move on to the next slide. So the next slide looks at metrics that are grouped under an access to care rubric. Maybe there's some time zone change here in Olympia. It looks like we're still on the service utilization slide on my screen, but I'm going to assume that we've moved on to the next slide. So these are measures of access to mental health services on the one hand, substance use disorder services on the other. And these are two homegrown measures where the denominator for these measures are limited to those who present an indication of mental health need on the one hand or substance use disorder treatment need on the other. Oh, sorry. Then we also have the HEDIS, a HEDIS measure that is, roughly speaking, a access to primary care proxy, although it's not exactly that, but it's sometimes something that we think of in that context. And if I were thinking about the design of these slides, it probably would have been a better choice for me to have us use a common scale, in which case it would be even more apparent that rates of access to substance use disorder services are far lower than rates of access to mental health services, or access to some ambulatory type of service that qualifies for the HEDIS measure. And when you think of this low access in relation to the prior slides, focused on the massive disparity in utilization, especially for those with SUD and co-occurring SUD or mental illness. And most people we see with SUD have co-occurring mental illness, about 70%. This really points to a huge opportunity for increased engagement in substance use disorder treatment to improve beneficiary outcomes, to contain costs. And these are the things that we hope better integration and a single point of accountability or fewer points of accountability will help us get to. An integrated organization who has the data to identify the presence of these conditions, has responsibility for the network of providers to treat this condition. And so we hope that we can move the dial on access to SUD treatment, as well as access to mental health care for folks with serious mental illness. The other thing you might infer from this slide is that the HEDIS AAP measure is probably not going to be a super useful tool for thinking about quality of primary care or physical health care in this environment. And that's because the information that we have to see to classify somebody as having serious mental illness or co-occurring mental illness or substance use disorder means that they're likely having health service events. We need to see those events to see diagnoses that would group them there. They're likely having health service events that are going to meet this standard of access to care. And so we need to look at other areas to think about quality of care. We might look towards medication adherence on the mental illness side and a variety of other things in the HEDIS family to get better at that concept. So I'm going to, I think I actually can do this here. So I'm moving on to the next slide. A couple of measures focused on 30-day hospital readmission rates. One is the standard Edith PCR, if you're into HEDIS three-letter acronyms, the all-cause readmission measure. There's a state-defined variant on that which restricts the admissions, the readmissions that we're looking for, and the discharges that we are focused on to those in the psychiatric facility of the various types that we have. And the one thing I'd point out here is that if you compare this measure to the inpatient utilization chart that was on the first data slide that we looked at, you'll see that overall utilization has far more risk signal to it than a 30-day readmission measure. And that's something I would encourage people to think about if they're doing measurement in this area, in addition to the fact that the overall inpatient utilization measure is much more directly tied to Medicaid program costs because it's capturing the full scope, or largely the full scope of inpatient utilization in the period. Okay, our last data slide, we'll be wrapping up just a few minutes here. So these are measures that we tend to put under the social outcomes rubric. Sometimes the social determinants of health phrase is used, and I feel slightly uncomfortable about kind of that full phrase. I think of these as outcomes that are outside of strictly the health sphere, but are certainly, as indicated by the slide, powerfully impacted, in particular by the behavioral health risk factors, with, especially on the housing stability and criminal justice involvement side, substance use disorder being the overwhelmingly most important driver of risk of adverse outcome in these areas. And if you were to line up those two slides, the homelessness and arrest slides, with those first two ED and inpatient utilization slides, that risk gradient is remarkably similar, especially between those with co-occurring SUD and the general Medicaid population. Again, you're to that roughly 3-to-1 likelihood ratio of the adverse outcome. Okay, one more slide before I close, and actually this is really kind of a repetition of points that I've made along the way. So among the key points I would fall back on, looking at utilization, including quality measures derived from utilization, with an attentive eye and growing and appropriate expertise and understanding the enrollment and eligibility aspects of measurement. That's going to be super critical. If you do work in the Medicaid space, you will find, I think, as an empirical regularity across all states, that behavioral health risk factors are incredibly important drivers of adverse outcomes or extreme utilization for Medicaid beneficiaries. And issues, number one with a bullet, access to substance use disorder treatment is probably the greatest opportunity that we collectively have out there to move the dial on a range of metrics in the adult Medicaid population, and we bring adolescents into that conversation as well. So I'm gonna pause here and turn it over to Sue for the next phase of the presentation.
Thank you, David. What a great, representation of what states are doing themselves from Medicaid data. So my job here is to looking into the future a little. I wish I had a crystal ball, but I don't. So this is more like me being a kid in front of a blueprint of a candy store. So getting very excited about the potential new flavors that I'll be able to taste in the coming years. So I'll be going through some of the advances made by TMSIS or happening under the TMSIS era and their implications for research on utilization. I'll try to provide two examples of the kinds of research questions that hopefully as researchers will get better answers under TMSIS. Of course, this is all based on a big assumption, which is in time, the data will be available promptly and their quality will be high. The data availability, quality, and completeness as currently may still pose some challenges, but with time, exploration, and more importantly, people using the data and showing what kind of wonderful things can be done with the data, as well as a lot of technical assistance, feedback from CMS, I have confidence that they will improve. So I'm going to introduce the 3 new data files that will become available under TMSIS. The first one is the managed care plan information file. I think this has been touched upon in all of the previous speakers' slides. This new plan information file has a record for each managed care entity identified by a state plan ID that is linkable to beneficiaries' enrollment, capitation payments, and encounter records. The data elements included in the data file has information on the profit status, service area of the managed care plan, percentage of business in public programs, as well as operating authority and reimbursement arrangement. For example, whether the plan is risk-based, do they have incentives or not. I could imagine those of you in the audience who has an industrial organization background could have a field trip with these kinds of data. The second brand new data file that will be available under TMSIS is a provider file. In this file, you will have a record for each provider serving Medicaid enrollees. All of them are identified by a state-assigned identifier, and again, linkable to claims and encounter records. If they are available, some of the states also provide national provider identification, which I imagine could be quite useful in data linking with other sorts of data sources and provider information. Here you have data elements such as ownership and location of the provider. If it's a group, you will know it, and you will also know the association, affiliation of the provider. You will know the sex and birthday of the individual providers, their licensing and accreditation information, as well as type and specialty. The last bullet point, I think, is also very intriguing to me, especially for those of you who are interested in provider network and access to care, whether the provider is accepting new patients. So the third data file new data file under TMSIS is the third-party liability file. David mentioned this in his presentation. Here you have a record for each Medicaid enrollee who has some form of third-party entity liable for payment for some or all of the medical expenses. This does not include, of course, Medicare. Here you have MSIS ID for the individual, again, linkable to eligibility and the claims or encounter records. You will know what is the insurance plan this person has, the group number, who owns the policy and the relationship with the beneficiary, what kind of plan type, what kind of coverage type, is it just for mental health or home health, and some financial information such as annual deductible amount. So in each of these new data files, by no means these are exhaustive lists. I'm trying to give you, again, that flavor of what could be potentially available. Now, in addition to the 3 new data files, there are other new or improved data elements in existing eligibility file or claims file you will find under the current data system. So again, these are only examples, and I try to pick out those that make me very excited about. We have tons more information about the beneficiaries themselves. We know more about waivers, which are getting taken advantage of more and more so by the states these days. We know more about special programs and waivers directly on the eligibility file, such as money follows the person. More importantly, on the service encounter records, we also now can see attached the waiver ID to those encounter records. For dual eligible beneficiaries, again, a huge part of Medicaid, and Lindsay and David both mentioned this. For them, we have richer information as well, such as amount paid by Medicare on the claim and the reimbursement type. Diagnosis is currently available in the Medicaid data system, but we have this new flag, which is present on admission flag, that helps identify certain preventable conditions that patients may incur during their stay, so very useful information on quality of care. On the claims and encounter records, TMSIS will hopefully get all these different types of provider identified, the admitting provider, billing, referring, servicing, and operating providers. On the payment side, this again I will mention later on in my presentation, Medicaid paid amount for the encounter claims, very, very useful information. For the drug part, I love those charts Craig mentioned in the beginning of the forum. Here, for example, we will have drug utilization code, which is part of what the National Council for Prescription Drug Programs usually require. That will tell you any conflict, intervention, and outcome of a prescription presented for fulfillment at the pharmacy. So again, quite useful information about any sort of drug-drug interaction, overuse, that kind of information. The next 2 slides kind of tell you a little bit beyond the data, which, of course, as researchers, we all care about. These 2 slides are kind of behind of the scene, but still very important in terms of timeliness and data quality. those of you who attended our previous forum know now that in TMSIS, data are submitted monthly instead of quarterly. There's front-end data validation rules that would assure completeness, and data element relational tests could, there's automated inferration measures that feed into a data quality compliance database for tracking data quality by state and along a certain timeline. Most importantly, even though not really precise a TMSIS improvement, but happens to be the case, the Medicaid CHIP managed care final rule came out under sort of this TMSIS era almost, which gives the CMS that piece, really, the explicit option to withhold FFP to pressure, basically, MCO and states to submit accurate and complete and timely data. I just wanted to mention, I think as last week, there has been some guidance provided by the state, by CMS to the states on their exact expectations and guidelines on reporting these encounter data. So there is, again, hope for very improved managed care data quality under TMSIS. I'm gonna skip this slide because we want to leave enough time for Q&A, but the gist of it is there's a lot of business intelligence tools now cooking behind the scene, and hopefully there's gonna be efficiency again, there's gonna be more user-friendly graphs and charts available in the future. So as I mentioned in the beginning, I would also like to give the audience some sort of specific examples on how things, the types of analysis one can hope for under TMSIS. I gave two examples here. First one is on managed care. In the past, and actually as currently standing, not all states report encounter data, and when they do, usability varies and quality varies. There's very little knowledge about how much services actually cost, and little information about the plans themselves. Now, under the value-based purchasing framework, one would hope to get more information from the managed care, but currently standing, most of the information are for fee-for-service only. Now, looking into the future under TMSIS, again, assuming the data quality will be there eventually, and the states are now required to submit the actual payment from managed care organization to the providers for specific services. So this is the Medicaid paid amount that I mentioned earlier. There's rich plan level information in the managed care plan file. One would hope there's much better analytic capacity at all levels, from managed care plans, enrollees, state, to cover a wide range of issues. Another example I want to give is on beneficiaries with complex needs and high costs. Again, a very hot topic these days. As we know, any cost-based BCN definitions can now only be applicable to fee-for-service beneficiaries because we don't have the equivalent for managed care enrollees. Most of the analyses are cross-sectional or among Medicaid-only beneficiaries, and there's little knowledge about these social economic conditions and living arrangement about what makes this population's needs complex. In the future, again, the managed care data improvement could play a big role here with more data points and more enrollee characteristics. One would hope to conduct more longitudinal analysis and predictive modeling with finer granularity. Very excited about location data. Now, TMSIS is trying to gather and improve data quality on. If we have more location information from beneficiaries, plans, and providers, you could imagine a lot of geocoding and heat map of ED visits, so on and so forth. I will come back to the data linkage point at the end of my presentation. So some of my final thoughts. As I put a plug in the very beginning, using the data to answer real-world questions is definitely one of the key things to help identify data limitations, demonstrate the utility, and incentivize states to submit higher quality data on time in the future. There is a practical question in my mind because we have, like any transition of old data system to new data system, there may be a few years where there's overlap of data. Things might not be quite consistent, so researchers definitely need to be very careful there. The table, which is available on CMS website, just gives you a sense of how the overlap looks like. And finally, those of you who have used Medicaid Analytic Extract, the MAX data before, would be very happy to know that we are currently constructing a researcher-friendly TMSIS analytic file, TAF, which it's sort of the future copy of MAX. In addition to TMSIS, there are other program, administrative, pharmacy, and financial data that together form the Medicaid and CHIP business information solution. And I know CMS is trying to build a data warehouse for the integrating of all of these information, so more to look forward to there. Data linking can increase research capacity exponentially. I think that's demonstrated in both Lindsay's and David's presentation. It's very hard. And in addition to the Social Security number that is currently available, I think TMSIS does provide more data on beneficiaries such as name, such as address, that could help validate any linking and maybe even do some probabilistic record linking. Finally, standardized reporting from TMSIS could potentially relieve burden on states, at the same time improve timeliness, reliability, and transparency of the data. So I think that's a sign both the states welcome as well as researchers. So like I said, this is just hopefully give you a taste of what to be looking forward to. I gave you the TMSIS information website on this slide, and really acknowledge all the architect and of course CMS behind the TMSIS. Basically, they are the builder of this candy store that I'm so looking forward to. So with that, I will turn back to Craig.
Thanks. Now we're all hungry, so. But I hope people will still take time in the audience to send in questions. As Bryce said at the beginning, you can use the Q&A widget on your screen to submit questions, and we'll get to those in a second. But sort of as a transition while we're waiting for questions to come in, I thought I'd ask the three panelists, that you guys have used utilization data a lot, and you know a lot about this. And so do you have advice, things that you wish you would have known when you started out that have proven to be very valuable, but tips for our audience, a couple things that might help them as they use these data? Lindsay, why don't we start with you?
Sure. So that's a great question, and I think I tipped my hat a little bit to my answer in the presentation where I said you got to read. So before you play with the data, you got to dig in. And if you want a front door, and I actually didn't do this until I was a fairly seasoned researcher, so I wish I had done this many years before, go and read the two forms for facilities and providers. I can't remember their names right now. One's the CMS 1500, I think, but the facilities form and the provider form is your best front door to understanding what these claim systems are going to look at. And I wish I had done that as a newbie.
Thanks. Sue, why don't we go you next, then we can go to David.
Sure. So in addition to reading, which is definitely something I agree with, I would also add know your state. So if you're doing national Medicaid sort of research questions, then too bad you've got to know all 51 states. I'm kidding, but my point is, no, not half kidding, I suppose. But really, I think David alluded to this in his presentation. Every state is different, and Medicaid is essentially 51 different programs. They have different population coverage. They have different benefit program design. The delivery system in each state can be quite different. The availability of managed care plans, the IT environment, and as waivers are getting more used to by states, it just adds the complexity of the program. And whatever difference states have in all of the things I mentioned will get reflected in the data. So when you see something that out of your expectations, don't just directly jump to conclusion the data is wrong. It could be a true reflection of the variation in the state programs. So know your state before you jump in. That would be my piece of advice.
Great. And just as Lindsay gave the example of the forms, I mean, I presume the Kaiser website's a useful place to go start.
Definitely.
Learn your state.
Yes. Yep.
So David, did you have a tip you wanted to offer the audience?
Yeah, those are great answers. So I'm going to largely kind of repackage those concepts. I would say, kind of more generally, learn the Medicaid business and understanding how providers bill for services, whether they're billing in a fee-for-service environment in the state or billing MCOs that are generating encounter data. That's essential. Also, if you're doing, I think I would very much agree, you have to understand the states with whom you're doing work, or with whose data you're doing work. And anything you can do to develop relationships with state subject matter experts on the policy, potentially on the IT system side, especially if you're working directly with state MMIS data extracts and not going through a national repository. But developing relationships with state subject matter experts on policy, IT system, program, clinical, that's probably going to happen more likely if you're doing work that focuses on questions that are useful to them. So I would encourage folks to think about doing this work with a focus on the business needs of the Medicaid program, and that some of those business needs might be at a CMS level. If you're doing state-level work, it's really going to be your state partners. And I guess the last thing I would say is more connected to a style of interaction. I would approach this with humility, because you're likely, if you're coming into a state Medicaid environment, you should appreciate how much you may not know. And even though you may have great technical skills, the quality of your work is going to be so dependent on what you can learn from folks with complementary subject matter expertise who are in the state agency environment. So approaching this with humility, I think, is a great way to help build relationships, and of course focusing on the business needs, so that you're producing stuff that's helpful as opposed to the risk that you might be seen more as a nuisance.
Thanks, David. So in other words, it takes a village to analyze Medicaid utilization data.
It really does.
So Keenan, I think we have some questions. Keenan's going to read the questions.
We do. We've received a couple of questions about managed care encounter data, as well as some just questions about what's overall in the data sets. So we'll start with the managed care encounter data question. Can you describe some of the reasons MCO encounter data fields may be missing? How does this vary by state and or the types of MCOs and their populations, such as disabled versus parents, et cetera?
Looking at me.
This is David. I'll just jump in quickly on that. If you're working directly with the state, the MCO payment data, I think, is likely to be pretty good because there are real financial transactions tied to that information. So on the state-by-state MMIS level, you're probably in really good shape with managed care enrollment data.
Yeah, I should definitely mention that Steve Considas, one of the architects that I acknowledged at the end of my presentation, is here with us because, like I told you, I'm not the guru who has the crystal ball. So he is a really expert on TMSs. So I'm going to turn the mic to Steve to see if he can share any insight about managed care data.
Yeah, I don't know how specific I can get, but I think the question kind of answers itself in that it really comes down to the state-specific conditions, the contractual requirements the managed care plan has to meet for the state and what kind of data they do report, what format they report it in, what schedule they report it in, the timeliness of it. That's all an arrangement between the state and their managed care plans. And CMS has provided guidance to try to standardize that at the state level, but of course not every state is going to be standardized yet. So it goes back to that point of knowing your state and knowing what their contractual arrangements are, what their program looks like, and what data you should expect to be available.
If you want more information about again, the data elements that are currently required for TMSIS, the state variation will be there, but if you want just to know what is required, you can go to the TMSIS website that is at the end of my presentation slide. And there is, I believe, still a data dictionary or code book there. So for those of you who want to spend some time digging into this.
But unfortunately, just because that data dictionary says that something's required,
exactly,
doesn't necessarily mean that at the state level that
it will be there.
Exactly.
Yep.
All right, thanks. Another question,
Sure.
Keenan?
Are there populations that are notably without utilization data? For example, are there claims data for the Indian Health Program patients to proceed without the limitations of survey research, such as a small sample size? Are you aware of any research going on in this population?
David, you want to take?
Yeah, let me jump in. Yeah,
yeah.
Let me jump in. We're a state that has probably a larger than average American Indian population, and if we are doing work that's focused on Medicaid enrollees, we do certainly understand that there may be some Indian Health Service or related utilization that we may be missing for the American Indian population. That said, we do see a significant volume of Medicaid paid services, enough such that if one were just looking at risk profiles based on health conditions, there is a somewhat higher acuity in the American Indian population, higher rates of risk of mental illness or substance use disorder. So although we may be missing some information, I think we certainly feel that we have enough information in regular Medicaid paid services to be able to, with careful consideration of what might be missing in the particular research question context, we feel this is a population that we can include in our analyses, provide information about, talk about disparities in experience and outcome, and it's something of a focus of some of the work that we do.
Thanks, David. Keenan, I think it looks like we have a long list of questions
yeah,
here,
we do
so
have a
we'll
long
keep
list
coming
of
back to you.
Will future Medicaid utilization data be available in a more timely and more consistent fashion across states?
One would hope.
When's this candy shop going to be built?
Right.
I know, and I'm not sure I can give you an exact date, other than say that CMS and a lot of people are working very hard, making sure that it's going to be available soon. So, Steve, do you want to add anything?
Well, just that maybe that there's still the last few states are still entering the production cycle of TMSIS and still catching up. So not necessarily all of the states are there yet. And so, of course, as states are catching up, data is being assessed for quality. All the states that have come into the system have already started this quality assessment program and have made drastic data quality improvements during the time that they've caught up on their data and remain current with it. So we expect that to see that with the new states coming in. So expect, every day that you wait for the data to come in, expect there to be improvements happening to that data. So it's worth the wait.
Steve, I can just extend the question one bit. So that if we're waiting for the national data, that's still a ways off. But there's still a core set of states now that have quite complete data. Mm-hmm. And so there are a number of questions or issues that people may be able to do right now. So is that 20 states, do you think?
I would say more than that. I don't know the exact number off the top of my head right now.
Well, if you
had a table slide.
Yeah. If you go back to that table slide, as of 2016, there were already Is it? I'm trying to.
Looks like
16 caught up through 2016.
I'm trying to see whether there's any mistake here, because I would expect that middle column should be. I'm wondering whether 35 and 16 are split.
This is as of January 2017.
Yeah, no, that's definitely, no, that's 2016. So I know there has been a huge movement in 2000, in 2017. But even with this table, I wonder whether there was a typo there, because I would expect those states submitted via TMSIS to increase from 2015 to 2016.
They just got in on January 18th. They're waiting for the Super Bowl to get it.
I think we should note, there's a lovely data map that is updated by CMS that will have the most recent numbers. It's on the website. It's a great resource. I check it often. It helps me as a dork.
And that was only added within the last month for those that haven't been to Medicaid.
Yeah, so check the data map on the CMS website.
So anyway, there's good data on a number of states, and we're on our path to getting data for the whole country. So, Keenan.
Yeah, getting back to managed care, how should researchers approach the measurement of Medicaid costs and payments when so much care is provided through managed care?
That's the hard question. That's why I was so hopeful for TMSIS, because right now that is precisely the challenge, because for more than half of the beneficiaries who have some level of managed care, we don't really have very good payment and expenditure data on them. But as I suggested in my presentation, there's more requirement on the MCOs and states to submit more data and the Medicaid paid amount. I think that's a great addition, and hopefully we'll know more about the actual payment from the MCO for the services that occurred under managed care. Lindsay, do you want to?
So I want to hop in here too, because I have used claims data systems directly from the states. I've used federal-facing the MAC data as well. And, I have something that's probably not going to be a very satisfying answer, but there's no shortcut, there's no heuristic, there's no user's guide. You have to do exactly what David said, which is know your policy SMEs in the states. Because I have worked with state data from states that have great managed care capacities, and I've worked with state data from states that don't. So there is just no substitute for lead work, really. And unfortunately, this is something that you kind of have to do on your own, reinventing the wheel. It's not something that's algorithmic.
But making progress is important. This has been a gap that everybody's seen for a long time, and it's nice to be moving forward on it.
That's right, and I think the states really are.
Yeah.
Yeah.
All right, next question from the field.
For dual eligibles, if a beneficiary is enrolled in both Medicaid and Medicare, can we know their Medicare information, such as the Medicare payments and inpatient services?
In the future, yes. Right now, I'm looking at Steve again. What do you think?
Well, in TMSIS itself, we expect, just like in MSIS, that we at least have that secondary payer information that if there was any monetary obligation for Medicaid to pay a portion of the claim, if Medicare was primary, we would expect to find that in TMSIS. Maybe
both Medicare and Medicaid, or just the Medicaid payment?
If you have both.
If you have both, you get.
And there was some obligation, there was a deductible or co-insurance, Medicare deductible or co-insurance that the beneficiaries are obviously not going to pay, so Medicaid may pay it. But I think maybe the question leads more towards other technical improvements, like combining the Medicare data set with the Medicaid data set.
So we could do a whole hour and a half just on linking Medicare and Medicaid data for the duals. So I want to just make another plug for the toolkit. There are a couple technical assistance briefs in the toolkit that pertain to linking Medicare and Medicaid data for the duals, and I just encourage folks to.
And the toolkit's available at the end of your slides.
David,
on the green widget.
Oh, and David. Oh, sorry.
And David,
sorry. Yeah, sorry, I wanted to jump in on this point, because I think what I've heard in terms of the Medicare payment data that might be available in MSIS or TMSIS, it would not be based on a separate integrated feed of Medicare Part A, B, or D data, or Medicare Advantage managed care data for the increasing proportion of duals that would be in Medicare managed care products. And if that's the case, what we know in our state is that the crossover payments that we would be submitting into MSIS and TMSIS now are really only a modest proportion of what we now see as the full volume of Medicare payments for duals, where we do have an integrated Part A, B, and D feed from CMS that supports our dual integration efforts. So I would say if folks think that they might be getting a full perspective on Medicare utilization for duals only from what's coming out of state MMIS systems, I think that's likely not the case. And especially the Part D side would be entirely absent.
All right. Well, hopefully we have a more uplifting answer to provide next time. So, Keenan, another question?
We received a question on David Mancuso's slide on access to care. The question is, what is the definition of service penetration, and what is the numerator on those rates?
Yes, so we have two homegrown measures of access to, on the one hand, mental health services, on the other hand, substance use disorder services. And essentially what we're doing is measuring those, so the denominator qualifying criteria would essentially map to, on the mental health side, presence of essentially a standard psychiatric diagnosis in a recent window of time, schizophrenia, bipolar conditions, depression, anxiety, ADHD, for example, or the receipt of psychotropic medications in those therapy classes. And then on the SUD side, something parallel to this, where we're looking for diagnoses of substance use disorders, alcohol or drug. That gets you, in a recent window of time, that gets you into the denominator. And on both sides, the numerator criteria are related to the provision of services that we would think of as therapeutic in that context. Mental health services that would include therapy, psychotropic medication management. We do put crisis encounters in there, so things that aren't necessarily reflective of routine care. On the SUD side, we limit it to services that, in the numerator, qualifying services that we would consider to be treatment. So methadone, buprenorphine, yes, those are in. Detox is not out, and is not in. We don't think of detox as treatment, but an inpatient or residential SUD stay would be counted as treatment. We do have Word document specs that we can share that provide more detail.
Thanks, David. Ian, next question?
We have sort of a request to speak more about the tools available for linking data, such as in the maternal and newborn populations. Is there more to say there?
Yeah, sure. So again, I'll point to the toolkit for actual URLs and citations, but I will mention that the best resources that I've leaned on for this have been metadata produced by other researchers, and metadata is documentation about data. And I think the two places that I look are users guides, linkage, technical assistance briefs that NPR researchers have often done on behalf of CMS. So there's the one that I mentioned on maternal infant health is through the Corset technical assistance. Good brief there. Also, really good info coming out of the Medicaid Innovator Acceleration, did I get that right? Accelerator program, excuse me, on data analytics, technical assistance. And then, like I said, do not forget to hop on PubMed. So whatever population you're interested in, you probably have a clinical researcher analog who's interested in that population too, and perhaps has published a paper on how they created a cohort for that specific application. And maternal and child health is one of the robust clinical literatures on this. So there's some really good work on linking and algorithms and all the technical details you'd want.
Thanks, Lindsay.
Going back to, I think it was David's recommendations about resources or learning how providers bill in Medicaid, what resources would you recommend that we can use to learn how providers bill in Medicaid?
Well, at the state level, at least in my experience, agencies tend to provide explicit billing instructions to providers, and those are immensely valuable resources to understanding the data. And this would connect with Lindsay's recommendation to look at the forms and understand that structure as well as the guidance that states would be providing to their providers, or that's primarily on the fee-for-service side. So then the question would be, can you get access to the MCO provider instructions? And there are some contexts where we do get that information, and it informs how we organize data.
All right, Keenan, next question.
Great. Will the new ICD-10 codes, particularly for the social determinants of health, be included in TMSIS? If yes, do we know how well these are going to be reported?
That's a national standard requirement for all providers to transition to using ICD-10 codes. So I would expect it to be good across the board for any provider that is obligated to abide by those are national requirements. Those are national beyond Medicaid, beyond Medicare. Every payer every payer basically followed the same implementation process. So I would expect it to be fairly standard across providers and states and programs.
And Steve, is there a rule of thumb in doing trend data about how far back you think the data will be okay, and then earlier than some date you wouldn't?
In TMSIS in particular, different for every state.
Okay. So you just got to read up on the state, as we've said over and over.
Yeah, and eventually when more data quality information is available, because as I mentioned, as states have been catching up on their data, they've been improving it. So we've seen that there's been certain states, certain aspects of certain states' data at a certain point in time, went from 0 to 100% quality, or went from 40% quality to 100% quality. So some of that information will come out through CMS published documents eventually as more data is disseminated for use.
Great, thanks. I think we have time for one more question. So, Keenan?
Sure. And this touches on, I think, the tools that Lindsay has discussed in David's slides. But how do you identify a co-occurring mental health and substance use disorder client? What's the process and data fields or elements that are used?
David, I think I'll let you.
Yes. So I'm trying to think about how architectural to go here, but basically, so we organize ultimately information about people and their experiences over time, and we can scan through all available claim and encounter information that might have an identifying diagnosis or related information that would group into an indication that somebody has a mental illness or substance use disorder. And just think of maintaining at the individual level a longitudinal record of all the various risk factors that individual is presenting using a grouping tool like the CDPS or other tools, and then being able to pick out, sort of line that information up in time with other information that means that individual is appropriate for measurement in the period we're reporting on, like they're enrolled in Medicaid persistently enough to qualify. We can line up their presentation of behavioral health risk factors in time in relation to that reporting period. So the flagging is really based on the conditions we see for the individual. It's not based on what specific services they might have received. Have they been served in the carve-out that's treating those with behavioral health disorders? That's not how we do it, because we're often concerned about how lack of access to those carve-out services for those who look like they need it is affecting other outcomes. And this penetration rate concept is a way of getting at our folks who look like they need services accessing them. So it's largely, we're maintaining a vastly dimensional, longitudinal record of individuals' experiences across measurement dimensions of risk factors that connect back to disease conditions, including behavioral health conditions, and lining that up with enrollment in Medicaid, enrollment with different accountable organizations, where people live, what their utilization is of services, what their experiences is of a range of outcomes like experiencing homelessness or are they employed and so on. So it's so there's an architectural framework in terms of how we organize data to support the production of this kind of information on the scale at which we do it.
Thanks, David. We're just about out of time, so obviously it's a technical question. People can follow up on the various resources. I want to remind people that there's a survey you'll get if you're on the webinar. We appreciate your feedback. We anticipate doing another one of these forums down the road, and we'd like to find out what you found useful so we can incorporate those ideas into what we're doing. I hope you understand, come away from the seminar, think about how valuable this data can be, but also how challenging it can be to analyze it. But the information generated from utilization is so important as we've given the pace and scope of changes. So we hope we've inspired you and given you a few tools. Use the resources that are up on the website. And again, thanks for your feedback on the survey and your participation today. And thanks for all the speakers. Bye now. Good afternoon, and thank you for joining us for this webinar on Medicaid utilization data. I'm Craig Thornton, and I'll be the moderator for today. Before we get started with the presentations, though, I'd like to turn the mic over to our coordinator, Bryce Overcash, to give you some tips about how to get the most out of today's session. Bryce?
Thanks, Craig. At the bottom of your audience console are multiple application widgets that you can use. You can expand each widget by clicking on the maximize icon on the top right of the widget or by dragging the bottom right corner of the widget panel.